Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical. And first of all, let me introduce myself. So my name is Dr. Arshan, and I am one of the mentor for First Aid AMC. Now, I understand that all of you are here because you already passed your MCQ, and now you are on to passing this very difficult exam. And I understand also that your dream is to pass this clinical exam as soon as possible and then get a job here. And we are here to help you with that. And I'll be very happy to assist you in this regard in almost every possible way. We have been taking this course for a long time. It's been about 5 years. First Aid AMC is helping with both MCQ and clinical examination. And many of you are already aware that this is one of the most successful courses among any course available in Australia now. And that you can see just by looking at our result every month. Almost every candidates who appear from the course, they pass the exam. And you do believe that passing a clinical exam in the first attempt needs a lot of guidance, as well as also it needs a lot of hard work from the candidates. Obviously, our candidate is doing a lot. They're trying their best to follow our guidance, and that's why they are passing. Whereas if you look around, you will find out people are struggling to pass this exam to get a job here in Australia. So that's why, like, First Aid AMC Clinical is one of the best at the moment. You will get every idea, not only just to pass the exam, but also you will get to understand the system that we follow in Australian health system. And also you will get to know that how to prepare yourself for the job market, because it's not about just passing the exam. It's also about getting a job after passing the exam, or even during your preparation of clinical exam, because now you are eligible to 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 also, like, you can apply for your job at the moment with your MCQ and English test, right? So you will get to know everything about job hunting. You will also know every possible scenario that can come across in your clinical exam. All right, so tonight we are going to focus on one of the most important topic, which is like, it will come in the exam in any way, that is your psychiatry mental status examination. And almost every one of you, if you are appearing the exam, you will get at least one case from mental state examination or psychiatry, psychosocial history, and just with the basic knowledge. So even with a basic psychosocial history, sometimes one case that comes from psychiatry can be covered. So we'll discuss that particular thing today and try to understand it, try to find out what actually is important. It's not about just having a good knowledge on topic. It's about communication. It's about approach. It's about how you present yourself in front of the role player, how you present yourself in front of the examiner. Everything matters. All right. And yes, the recording will be available after today's session. So you will get it in our First Aid AMC Clinical official group. So in case you are in a hurry, you can always just skip the class and then get to listen to this recording afterwards. That happens in every classes, like in our main course classes. If you are not able to join the live session, you can always get the recording in our system, and you can always finish that in your own time. And also you get a long access to the recording even after finishing the course, which you will not find in any other courses, that I can assure you. All right, so before we start with our trials class today, let us go through the clinical examination as a summary, that how it occurs and how you should prepare yourself. What is the scenario currently going on in Australian AMC preparation? So everything in a nutshell, let me discuss first. In case you have any questions, you can always ask me in the chat box. We try to keep yourself muted during the class because it makes the class pleasant for everyone, because then there is a lot of noise happens around everyone. So you can always ask questions in the chat box. I always keep the chat box open in my laptop. So I will always see that what you are writing and I answer immediately. So that's not a problem at all. I can see a lot of you are in our Facebook group. So if you want to come to the Zoom session, the ID is already given. You can always pop up here, and then I don't need to look at the Facebook comment as well. But if you wish to be there, that's also fine. I can always look at the comment section, and then I can answer your queries as well. If you have any questions about the job scenarios or anything like that, we're going to have a session very soon, early next month. There will be a job hunting sessions regarding your CV, your selection criteria, how to apply the RMO campaigns, everything. We will have a discussion very soon. So let's not discuss about that today. We will discuss on that session about this topic. Now, clinical examination. I am sure that you heard a lot of negative things about clinical exam because it is actually hard to pass. I will not say that it is very, very easy. I will never say that everyone can pass it in the first attempt. I will say that if you try best, if you try hard, whatever your accent is, whatever your communication level is, you can pass the exam. It always comes with a lot of preparation. So I've seen a lot of people who doesn't have a good way of communication, but later on throughout the course, they have learned that way. They have learned how to communicate, how to show that no, my language doesn't matter. What matters is that how I approach my patient. If you are a good doctor, you can approach a patient in almost every languages. So language accent doesn't matter. So if you are struggling with your accent, if you're struggling with your way of communication, then it's not a problem at all. You will learn the way, because there are phrases that we use in almost every scenarios. And you don't need to have a very good accent for that. We'll show you the way to communicate properly with the patient. All right. So in your AMC clinical examination, there are now two kinds of exam going on. One is face-to-face, another you are getting online examination. Online was like pretty much every exams were online in the last year. But now in 2022, the scenarios are getting changed. It is now being converted into face-to-face exam mostly. A very few schedules are available for online exam. And I have heard that like AMC also not giving you the online format until the face-to-face exam is all covered. So it is getting hard. And because a lot of people in the last 2 years, they prepared for online format, a lot of candidates are also applying for online at the moment. So it is getting oversaturated. And obviously, AMC does not want to continue the online exam format because it is hard for them as well to continue two format when COVID situation is kind of moderate at the moment. So things will get changed to face-to-face eventually at the end of this year. So I would rather suggest to, like if you are starting your preparation from today or from few months, you should prepare yourself for face-to-face exam rather than just lingering your exam for online. That is my advice. But if someone is like adamant, no, I am going to appear for online exam whenever I will get my registration, I will apply for it. That is also the choice available. That is not a problem at all. If you want to pursue on the online exam, we will also help you with that. There is no issues with that because we have an extensive discussions on online exam because the last one or 2 years, we did a lot of research on online And as you could see that like a lot of candidates passed from our course just for that online exam format. So that is not a problem at all. Whatever is the format is, you have to pass 10 out of 14 stations to pass clinical exam. Now, clinical exam is a kind of OSCE examination. A lot of, like many of you has appeared almost few OSCE examinations in your life already. So you have some idea about it. In some countries, those are called short cages or long cages. So same thing like this. Now, in case of clinical exam, especially if it is a face-to-face exam, you have to go to the exam area, which mainly happens at the moment in Melbourne, Australia. You will not get anywhere else. So that is the only place where we are having the online, where we are having the face-to-face exam. So in face-to-face exam, you go to the Melbourne Center, and then there will be some medical student most of the time who will greet you, take you from the lift upward to the main room. And then they will give you some badge as your identity. They will also show you around. They will give you some presentation that how the examinations are going to happen. You will be able to take only your stethoscope with you, nothing else, not even a watch. You can take your bag, but the bag or anything else will be in some cover. So that's how it happens initially. They will give you a card which will hang around your neck, and that will be your identity throughout the exam. There will be 16 rooms. In 16 rooms, there will be one examiner and one role player. And outside that room, there will be a monitor which will give you the exam question. So you can visualize what I'm trying to say. So there are 16 rooms. In 16 rooms, there are 16 stations. In each station, there is one examiner, one role player. Outside that room, with the closed door, there will be a monitor which will show the exam question, or we call it STEM. That STEM, you will be able to read for 2 minutes. Once 2 minutes is up, there will be a small bell, and that means your 2 minutes is up. You go inside. You open the door, an examiner will greet you and ask you to show your identity card. You show your identity card, examiner will then introduce you with the role player. And at that time, examiner will say what is the name of the role player, which is very important for you to remember because you have to address that role player by that name. So always try to remember it. Once you go inside, then your 8-minute time will start for the whole station. So as a whole, you are getting 10 minutes for each station, 2 minutes outside as a reading time. You can't write anything at that time. You can only think that what you are going to ask about this station. And then you go inside and you finish the case in 8-minute time. Now, the case task will vary depending on what they actually want from you. Sometimes they ask you to take a history from the patient, then ask for physical examination from examiner, where you have to ask the finding of physical exam from examiner. Sometimes they ask you to ask for investigation from examiner. Sometimes they ask you, like, give the diagnosis and differential and outline the management plan with the patient. So these are possible tasks that comes. So history, physical examination, diagnosis, differential, and management. So in every case that you are going to prepare, this will be your preparation. You will prepare how to take a history, how to take physical examination, how to, like, what will be your diagnosis and other DDs, and also management. All right. So now that you got some idea, right? At least you know that how this exam is going to happen. So every 4 stations, you will get a break after 4 stations, or we call it a resting station. So 4 station, you go for a rest, and then again 4 station, you get a rest station. In this way, there are 4 rest station as well. Each of the rest station are also 10 minutes. You can't do anything apart from drinking water or just thinking what you have done in the previous station, which I would say not to do, because that will kill your next station. So that's your face-to-face format. Now let's discuss a little bit about online format. In online format, someone's microphone was on. That's why I always mute everyone. That's fine. So for online examination, you don't need to go to anywhere, because it will be just like you will be in front of a computer or a laptop. Through the Zoom, you have to appear that exam. And in online examination, they will first, obviously, you will register yourself for the exam. They will send you some identity verification things in your postal area or as a mail. And then you will use that one to verify yourself in the exam. In online examination, first of all, everyone who is appearing the exam will be in the Zoom session, just like you are having at the moment. But at that time, there will be only 16 or 32 students in one session. Each of those students will be divided into some separate Zoom sessions later on. Same like your face-to-face exam, they will also give you some presentation how this exam is going to happen and everything. That will be done by an invigilator who is not an examiner. Remember it. So invigilator, the role of invigilator is to conduct the exam. So he or she will help you throughout the exam to understand, or if you're having any internet issues or anything. After that, when your exam will start, they will send you in separate room. And in each of the room, you will be rotating 16 rooms in this way. And in each room, there will be one examiner, and you will not be able to see examiner in any online exam. So examiner's video will be off. There will be invigilator. There will be a role player who you can see and talk to. So examiner will be there. You can't talk to examiner. Examiner also will not answer any questions that you can have. So you will never ask anything from examiner in online examination. Whereas that is totally opposite in face-to-face. You can ask anything from examiner, because examiner is the only one who can help you during face-to-face. There is no invigilator. All right. And in that way, again, you will get 2 minutes to read the station and then 8 minutes to do your case. So 10 minutes in each of the Zoom session, you will rotate around and you will finish your station, just like same as we discussed from face-to-face. So that's a fair bit idea about your online examination. Okay. Now that you know the format of online and face-to-face, and also you know how much station you need to pass for this exam, so you know that there are 16 stations. Out of 16 stations, 2 stations will be pilot station or non-scored station. But unfortunately, just like your MCQ exam, you will not know which one is pilot. So every station is equal for you. Out of 14 scored stations, you have to pass 10, and then you can pass. There is no recall. You can't. There was previously, like, if you just pass, like, you can do a reattempt. That reattempt is no more available in clinical examination. You have to give the full clinical exam if you fail. But I can assure you, if you follow the course, if you follow our guideline, there is almost no way you will fail the exam. But obviously, I can't say that like 100% will pass. It has to come from you. You have to give your 100%. You have to really work hard, and then I can assure you that you will pass this exam. So lots of discussion, right? Now let's move on to our psychiatry session tonight. A lot of things that I discussed, many of you already know, but there are people who doesn't know anything. So this is for them, so that you understand what you are starting with. You are having some idea at least. So psychiatry. In psychiatry, we are mainly focusing on taking a psychosocial history, which you can use in almost every psychiatric station. The basic thing that you will learn from us, that you will be able to use this in your rest of the life when you will be joining as a doctor in Australia. So still now, we use the same approach when we talk to a patient. So that means that this is something which you are learning for the rest of your life, which you can use. So make sure you understand it properly. And if you don't, then do not forget to ask me repetitively. I will repeat it multiple times, and then you will understand it. I will make sure of that. So starting a psychosocial history involves taking a good history from a patient. And that history starts with giving a very appropriate confidentiality to a patient. When you talk to a patient who is mentally unwell, you have to offer them enough room to talk to. You have to make sure that you as a doctor have to be that much friendly and empathic so that your patient can talk to you frankly without feeling any judgment coming out from you. Your movement, your gesture, your tone, even your hand movement, your mouth movement, everything matters in this case. Especially for psychiatry, how you talk with a patient, it matters a lot. Because depending on that, a patient might open up to you, a patient might just totally off. They will never ever talk to you. And if that happens in your exam, that is permitted. So if you don't offer them enough confidentiality, it is permitted in the exam that role player might not answer any of your questions properly. They will talk to you, but they will not give you any information which you need for this station to pass. So that's why this psychosocial history is so important. And the first step of it is to offer a good confidentiality to the patient. Make the room appropriate. Make sure that patient doesn't feel any negative vibe coming out from you. So that's actually your job as a doctor, so that the patient feels comfortable with you. All right. And you can't expect that a psychiatric patient will be very nice to you, because that's not how it happens in reality. The person who is not well mentally, he or she will not be like very nice or very polite with you many times. That doesn't mean that you will not be polite or empathic to the patient, because you know what is wrong with this guy. So you have to make the patient comfortable. You have to make that room so that even the meanest patient talk to you nicely. Okay, and that's your job, not that patient job or not that examiner job. So how we usually start a psychiatric history, let's say that you have got a patient who is having some recent change in their behavior, and the wife is very concerned about it. That's why wife brought this patient, or wife brought her partner to talk to you. And in here, the partner is here, wife is not present in the room. So you have to talk to the patient and find out what's the change in behavior wife concerned about. Now, there are two approaches in confidentiality. One is the conventional approach, which almost every candidate in the exam uses. And that is very mundane for an examiner to listen to the same statement from 32 candidates again and again. So you should make yourself a little bit unusual, I would say. I would say, like, make yourself a little bit exceptional from other candidates so that the examiner thinks, no, this is the candidate who is not using same language like others. Maybe this candidate is little exceptional. So let's hear what she is talking about. Sometimes examiners become so bored, so tired, sometimes even they don't listen to you. So that's also your problem, not examiner's problem, because you are not making things interesting for him. Okay? So what you have to do, make yourself little exceptional. So I always ask my candidates to use some alternative approach from their own head. It doesn't have to be what is written in here. You can make your own statement, and that will make you exceptional from others. So first of all, the approach will be something like that. So let's say the patient name is John. So, hi John, this is Dr. Arshan. I'm one of the doctor here. It's very nice to meet you today. I understand from the notes that your wife is concerned about some change in behavior that she has noticed. I really appreciate that you are here to talk to me. I want you to understand that whatever we talk today, it is between you and me unless it is harmful for you or others. So that's your conventional statement. That means everyone will use this line that, let me assure you, whatever we talk today will be between you and me unless it is harmful to you or others. But I use always a little bit extra. So what I would say, I would start the same way, like, I really appreciate that you are coming here today to talk to me. John, I want you to know that I'm here to help you today. And I want you to understand that if there is anything that's going on with you, you can talk to me. There is nothing that you can say that will make me just or embarrassing about you. So this room is open space for you. You can talk to me frankly and directly about anything that's happening in your mind. And I'm here to help you in every possible ways. And I want you to reassure that the discussion that we are going to have here, it is confidential between you and me. So I have used that sentence at the end, but I have made a room for the patient so that that patient will understand, will know this doctor is not so bad. Okay, maybe he's not from my country, but no, this doctor is not that bad. So let's talk with this doctor. So practicing in Australia is never ever same like how you practice in your country. But you can always make difference. Your ethnicity, your gender, your nationality doesn't matter here. You can make difference if you are a good doctor. Okay, so make yourself like that so that patient feels comfortable to talk to you. So I will always ask you to use something first to make that comfortable area for the patient. So you can use anything that comes in your mind. It doesn't mean that you have to use this exact same sentence. Then sometime later on, after a few months, this will be very usual for that examiner. So use something that comes from your head and make sure that patient feels good after talking to you. So anything like, you can talk to me directly and frankly, John. There is nothing that will make me feel embarrassed about you. And there is nothing that you might be ashamed of. This is a safe and open space for you. You can talk to me about anything going on in your mind. And I can assure you that whatever we are discussing here today, it is confidential between you and me. Then there will be no patient who will be shut or who will not open up with you. Trust me. Once patient is good, patient will start talking to you. Patient will say, doctor, I don't feel good nowadays. It's just something going on in my head. I can hear God, and God is asking me to do some good to the people, but I don't understand how I'm going to do that. So patient will open up with you, and then you will know what is this case all about. Okay. Now, once you start your psychosocial history, it will start with the same sequence. You can change the sequence depending on what is the actual presentation. Like if a patient is saying that I can hear God, we will go to the hallucination question first. But let's say patient doesn't say anything, or patient says that I don't feel well, doctor. So in that case, you can start asking from this sequence. So first question that we ask that, John, how is your mood these days? Patient says that, yeah, doctor, I feel very low all the time. The next question we ask that, how long you are feeling this way? Because duration is also important to know that how long this is going on. So always ask, like, how long this is happening with you. Is there any time you feel really good or excessively high? Why we ask that question? Because if a patient's mood is low, that suggests that it could be a depression. And depression sometimes can be masked with mania. That means sometimes a patient can have depressive episode, and in some other states, they can have manic or hypomanic episode, which together we call bipolar disorder. So that's why whenever we ask the questions, we ask, how is your mood these days? If patient says low, then how long this is going on, John? And then you can ask that, is there any other time that you feel excessively high or good? No, doctor. How is your sleep and appetite? So if patient says that, yes, doctor, I'm not sleeping well, what is your next thing that you say? You say, I'm really sorry, John. It must be very stressful for you. So can you tell me that this sleeping problem you are having, did it also start the same way, or did it start the same time when you started to feel low? Yes, doctor. So sometimes when we get a sleeping problem, we also ask a little bit of detailed question. We try to ask that. Now, we are not actually going in that detail today, but if you want to know, then we ask 3 questions. So we ask to the patient that, do you have difficulty in sleeping, or do you have difficulty in initiation of your sleeping? That means if a patient has difficulty to fall asleep, that suggests anxiety disorder. The next question we ask that, so do you have difficulty falling asleep, or do you wake up early in the morning? If a patient wake up early in the morning, suggests depression. The next question, if patients say, yes, doctor, I wake up early in the morning. Next question we ask is that, do you have difficulty falling asleep again? Yes, doctor. Do you have multiple broken sleep at night? Yes, doctor. Any nightmare? No, doctor. So these are the questions that we ask. So if a patient having difficulty in initiation of the sleep, that's anxiety. If a patient waking up in the morning, like early morning, that's depression. Multiple broken sleep at night with nightmare suggests a possibility of post-traumatic stress disorder or PTSD. So these are the questions we will be asking if we get any of the positive finding. So now you understand that we normally ask detailed question if we find something positive. If we don't find, then we just go to the next question. So we are asking about mood, we are asking about sleep and appetite. Next is to assess their suicidal risk. So first question that we will be asking is that, do you think that your life is worth living? Or do you have any passing thoughts of harming yourself or others? So any of these two questions are fine. So if patients say, yes, doctor, I feel my life is worth living, then you go to the next question. If patient says that, no, sometimes I feel my life is totally meaningless, what is your next statement? Say that, I'm really sorry that you feel this way, John. John, did you ever try to commit suicide? At the moment, do you have any definitive plan to commit suicide? If yes, then ask the detail that how he is planning. And do you have any access to any weapons? So those are the questions that we ask if we get suicidal risk positive in a patient. Now, in a psychosocial history, if we don't ask these suicidal questions, there is a high chance you will not get enough mark in this station. Because this is very, very important. Once you have asked it, the next question is important. So we move on to hallucination and delusion related question. So before asking this question, we always say that, John, I'm going to ask you some screening questions that may seem quite strange to you. Is it all right with you? Yes, doctor. Because if you ask a normal person that do you see or feel things that others don't, they will immediately ask you that, what is this bullshit, doctor? Do you think that I am a crazy person? Why you are asking this to me? So a lot of time candidates get this kind of confrontation from the role player. So to avoid that confrontation, you always say this line first. Say that I'm going to ask you some screening question that might seem quite strange to you. And then patient will not bother with you. So for hallucination, we ask that, do you see, feel, or hear things that others don't? For delusion, we ask a couple of questions in here. So see means visual hallucination, feel means tactile hallucination, and hear means auditory hallucination. And that is a part of mental state examination we call perception or perceptual disturbance. Next is delusion, which falls under thought content in MSc. So in delusion, we remembered this mnemonic RCGGP. So R means delusion of reference, delusion of control, delusion of guilt, then delusion of grandiosity, and paranoid or persecutory delusion. Okay? So these are the 5 questions for delusions that we will be asking. So first question that we ask is from persecutory delusion or paranoid delusion. So do you think someone is spying on you or trying to harm you? Then there is delusion of control. So do you think someone is controlling you? Do you think people are talking about you? That's delusion of reference. Do you think you are guilty about something? That's delusion of guilt. And do you think that you have some special power? That's delusion of grandiosity. Now, these are important findings in the exam. If you don't get it right, high chance the MSc station will be failed because they give you positive findings from here. So if a patient says, people in the street is commenting on everything that I am doing, that's delusion of reference. If they say that, yes, someone is controlling my thought, everything that I am doing, they are controlling, I'm not doing anything, that's delusion of control. The neighbors are trying to kill me, or the neighbors are trying to poison my food, that's delusion of persecution or paranoid delusion. Many a patient can think that they have some superpower. So that's delusion of grandiosity. Sometimes, depending on the case, you will understand that what delusion they can have. Like a patient who has depression, they can have delusion of guilt. A patient who is having schizophrenia, they can have paranoid delusion, delusion of control, delusion of reference. Whereas a manic patient sometimes can have delusion of grandiosity. Apart from these 5 questions, we also asked another 2 questions for delusion. So thought insertion, thought withdrawal, and thought broadcasting. So do you think someone is inserting or withdrawing thoughts from your mind? Do you think your thoughts are being broadcasted in a TV, newspaper, or radio? So these are also delusion questions. So someone is inserting thought in my mind, that is delusion of thought, or you can say just thought insertion. Someone is taking all thoughts from my mind, that's thought withdrawal. Thoughts are getting broadcasted in TV, newspaper, radio. That is what we call as thought broadcasting. Okay, so in thought insertion, thought withdrawal, and thought broadcasting, these are also 3 other delusions that a patient can have. Okay, once you have asked hallucination delusion, then there is 3 things that we ask. These are part of your MSc presentation. So insight, judgment, and cognition. For insight, we ask the patient, do you think that you need some medical help? If a patient says, no, I don't need any help, I am the messenger of God and God will protect me, that means the patient is not having insight to the problem. Judgment, we find out what is the level of judgment for a patient. So we ask the patient, let's assume that there is a fire in this room. What will you do at that time? A patient who has judgment, they will say, oh, I will run away. A patient who is having lack of judgment, they will either say, I'll be here, fire cannot touch me because I am the messenger of God. Okay, or sometimes they might not even understand how you ask the question. Okay, and they can say that, oh, there is a fire in this room. Where is the fire? So any of these 2 can be there in a schizophrenic patient. The next is cognition. When we find out the cognition, we try to find out if this patient is oriented to the time, place, and person. So we ask the patient, do you know where are you at the moment? That is orientation to place. Do you know what is the date today? And do you know who I am? So that's orientation to the place, person, and time. So once you have finished insight, judgment, and cognition, the next thing we ask in every psychosocial history is heads. Heads and SADMA, you will get to know these things a lot throughout the course. So what is heads? Heads is a mnemonic for a couple of questions that we ask to find out the home situation or work situation of a patient. Because these are the 2 areas which can impact a person's mental health a lot. So H is for home, E for education or employment, A for any other activities, D for, we use it for either for diet or sometimes drugs. S for stress, another is for support. Okay, so now you don't need to ask everything that we have said here. Only thing that normally we ask is, how is your home situation? Or you can ask that, who do you live with at home? And how is your home situation? Is there any stress at home? Do you do any work or do you study? Is there any stress at your workplace or at your university, depending on where the patient is now? So if patient working, then is there any stress at work? And lastly, you can ask that, do you have enough support? So those 3 questions are enough for heads. After that, we ask the SADMA. For SADMA, mainly we focus on smoking and alcohol. So do you smoke or drink alcohol? We also sometimes ask about medication, recreational drugs, and any allergies. But only thing it is important in psychiatry is that, do you smoke or drink alcohol? Any other recreational drugs? Now, sometimes patient can say, yes, doctor, I drink alcohol. You have to find out how much in a day. So how many drinks in a day? 6 drinks in a day. So more than 2 for women and 4 for men is harmful for a patient. And that is not a standard for a patient in here. So then you say that, John, if you please give me consent, then I would like to discuss about this alcohol in another appointment with you. You don't arrange appointment without the patient consent. You also don't say that this much alcohol is harmful for your body. You never say anything like that. You just say that, John, if you give me the consent, I would like to make another appointment to discuss about alcohol. That's all. After that, lastly, we finish this psychosocial history with past medical history and past mental history and family history of any mental illness. So ask about the patient that, are you generally healthy? Is there any other medical condition that you have got? Any past history of mental illness? Any family history of mental illness? Sometimes, if we have some time, we can always rule out some organic causes. What are the organic causes that can mimic psychiatric issue? Especially thyroid disorder. Sometimes even a patient having high fever or high infection can present as some psychiatric patient, like it can mimic, or sometimes even after head injury. So 3 questions we ask to rule out these organic causes. For thyroid disorder, we ask that, is there any recent change in your weather preference? Why we ask it? We can't ask the patient that, are you cold or heat intolerant? We ask the patient that, have you noticed any change in your recent weather preference? If patient doesn't understand that, then always we can explain that, do you feel cold even if it is a hot weather? A patient who is having hypothyroidism, they will always feel cold and they have this cold intolerance. Exactly opposite happens in hyperthyroid patient. And also we can ask any recent head injury, any recent flu-like illness. So that's how you finish your psychosocial history. Okay. Lastly, thank the patient for all the information and you go to your examiner to present your finding. So if we give you the summary again about the psychosocial history, so it will start with introduction, a gentle approach always. Then you start your confidentiality statement. After that, we start our psychosocial history with mood, sleep and appetite, suicidal ideation or suicidal risk, hallucination, delusion. We ask about insight, judgment, cognition. We ask about heads, SADMA, past medical history, family history. So only thing that you need to keep in your head is these points, because those are the important thing and you can use it in almost every psychiatric history. Now we have been talking a lot about MSc, right? So what is this MSc? MSc is the mental state examination. So most of the time the question will ask you that, take psychosocial history from the patient. That is what we have done just now. And the next task will be present your mental state examination finding to the examiner. So then you have to present what you have found out from your history to the examiner. And you can't just use, like, you can't just say the positive findings or negative findings. You have to use this format because that's how it is. So the format has a mnemonic that you can remember called aseptic J3R. So what is this aseptic J3R? A is for appearance and behavior. So we comment on like if a patient is well-groomed, well-kempt, or if the dress is like peculiar dressing or not. So we'll just appearance and behavior can give us a lot of clue about a mental health patient. Then there is a speech. Then there is emotion, which is mainly when we ask about that how is your mood these days? This is the question we are asking. Perception, that is the hallucination question we ask. Then there is thought form, which we will discuss later on. Then there is thought content. So there is 2T, right? So see this 2T. Thought content is your delusion question. And then there is ICJ, insight, cognition, judgment. And lastly, 3R. 3R means how risky this patient is. Were you able to maintain a good rapport with the patient? Rapport means relationship. And was the history reliable or not? So risk, rapport, reliability, that's your 3R. So we will use this format to present our finding to the examiner. All right, so you have to memorize this aseptic J3R. Sometimes when you go for your exam, in the 8-minute inside, you will be able to write anything that you want in a paper, because on the table, they will allow you to have a paper and pen. And that you can't take from outside. The paper and pen will be on the table and you can just write things. I always write the patient name so that I don't mix it up. And I will always, if it is a MSc presentation case, I will always write aseptic J3R on the paper so that during my presentation, I can have a look at the format and I will not miss anything. And that's the way to deal with this type of station. Now, moving on to, so let's say that you have already finished your history. So then your next task is to present this finding to your examiner. So how we will do it? So we'll say that, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old patient found by his partner trying to hang himself in the garage. Now, let's say that it depends on the history that you get. So let's say this is the patient who was found by the partner trying to hang himself in the garage. So that you always give the what is the main presentation for this patient. After that, you will say, so hear me out that how I am presenting this MSc, you have to do exactly in that way. So dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old doctor who was found by his partner trying to hang himself in the garage. In terms of mental state examination, he was dressed appropriate to the weather. He was well-groomed, cooperative, and maintaining enough eye contact throughout the conversation. I did not see any abnormal body movement or posture. His speech is normal in rate, volume, and tone, and there was no slow monotonous speech or rapid pressured speech. In terms of emotion, according to the patient, his mood is low and that the affect that I have observed is congruent with his mood. He did not have any auditory, visual, or tactile hallucination. His thought form was linear. In terms of thought content, he did not have any deviations. He was oriented to the time, place, and person. His insight and judgment was intact. He is a high-risk patient because he was trying to commit suicide. I was able to maintain a good rapport with my patient, and the history that was given was reliable. Thank you, examiner. So that is how we present this MSc to the examiner. Now, I understand that you did not get a lot of things that I said. I just wanted to give you an idea that what is MSc presentation. Now, let's come to the initial thing, that what are these step-by-step discussion that we are doing. So the first in aseptic J3R is your appearance and behavior of the patient. So when you get a patient in front of you, you look at that if this patient dressed appropriate to the weather or not, if this patient well groomed or very untidy or unkempt. During your conversation, if the patient is cooperative with you or not. Very important comment is this one, that was the patient maintaining eye contact with you? The patient who does not maintain eye contact, those are usually the depressed patient. So like usually a depressed patient will always look down and will be very slow, monotonous speech and taking a long pause in between. And it will be very hard for you to even hear them, because most of the time they will be very sad and gloomy. They will even sometimes cry in front of you. So maintaining eye contact is important. So if it's a depression patient and you don't say that patient was not maintaining eye contact, that means you missed a key point. Then we look for, is there any abnormal body movement or posture? Sometimes depressed patient will sit in a stooped posture or leaning forward. So they will be leaning forward, looking down. That is a stooped posture, which can be found in depression. You can see that frequent fidgeting, like touching the both hands, that fidgeting usually found in anxiety patient. Restless or agitated, like sometimes mania patient will not sit in one spot. They will just stand up, they will roam around the room. So that restlessness is usually found in mania. But in a schizophrenic patient, it's quite commonly given in the exam that they will be distracted. And sometimes you will see that they are looking at the ceiling, looking at the door, as if someone is talking to them. So they're actually trying to show to you that this patient is having some visual hallucination. So at that time, you have to comment that my patient was distracted and seems to be responding to some unseen stimuli. So that's what we usually use in a schizophrenic patient if you get this finding in the exam. So that's your appearance and behavior comment. So if the patient is dressed appropriately, well groomed or not, cooperative or not, maintaining eye contact or not, is there any abnormal body movement like stoop posture, frequent fidgeting, restlessness, or if the patient seems to be responding to some internal or unseen stimuli. So that's your appearance and behavior. The next is speech. In speech, we mainly comment on three things. One is rate, volume, and tone. So in patients who are having mania, the rate of speech will be very rapid. So they will talk rapidly, very loudly, and it will feel like pressured speech. So rapid pressured speech is usually we find in mania patient, whereas patient with depression, they will have a very slow and monotonous speech. Like, how is your mood these days? Patient says, like giving a lot of pause in between, then sometimes maybe 5 seconds later, I feel very low. There is nothing for me in this world. So see that how slow it is. Unfortunately, this happens in exam, and you will feel like, oh my God, why he is talking so slowly? I'm running out of my time. So that happens. So you have to be calm. You can't rush them because that is how this case is. So you have to be like a little patient, making sure that in some time you will ask multiple questions to the patient, so that the time that he is killing, you will make up for it. We'll show you how to do that. So we first comment that if the patient's speech is normal in rate, volume, and tone, or if it is slow and monotonous, or if it is rapid and pressured. Sometimes in depression patient, they will take a long pause in between each sentence they are saying. So you can always say that patient was taking pauses in between. In mania patient, they might not answer your question appropriately. They will just talk and talk and talk, and they will not listen to you. So then you can say that my patient was not answering question appropriately and spontaneously. But in psychotic patient, sometimes they can have a disorganized speech that you don't even understand what they are talking. But in exam, that will not happen, because in exam, you need to know what they're talking. Otherwise, this case will not be there. So they don't give you disorganized speech patient in exam. But in real life, it can happen. So that's speech. After speech, we have emotion. So aseptic, right? So in emotion, there are two things, mood and affect. What is mood? Mood means that when you ask a patient that how is your mood these days, patient says low, patient says normal, patient says I don't know. So whatever patient says, the exact thing you will say here. So you will say, according to the patient, his mood is low or his mood is all right. So it depends on what patient says their mood is. But what is affect? Affect is that as an examiner, because you are examining the patient now, as an examiner, what do you feel about the mood of this patient? So if you feel that, yes, this patient looks sad, then you can say, and the affect that I have observed is congruent with his mood. Okay? But sometimes in psychotic patient, when you ask that, yes, how is your mood these days? Patient say, yeah, it's okay. But you will find out that patient is not okay. Patient is disturbed. So at that time, you say that according to my patient, his mood is okay, but the affect that I have observed is disturbed and it is not congruent with his mood. All right. So that depends on what you get in the exam. After emotion, we have perception, which is the hallucination. So we already know that what are those hallucinations. So auditory hallucination, visual hallucination, and tactile hallucination. So as SIP, so then there are two T, thought form and thought content. Now thought form can be quite confusing for you. So thought form, a normal person, when they talk, they always think, right? Like whatever we are talking about, we think that this is the thing what we are talking. And when a normal person talk and it makes sense, that means their thought form is linear. That means like if you ask a person that what is your name and they say Mike, that means their thought form is still intact, and that is what we call as linear thought form. But there are people or patients whose thought form is not normal, especially for mania as well as schizophrenia patient. Like in case of mania patient, we get a thought form called flight of ideas. In case of schizophrenia, we get loosening of association, which also include tangentiality and circumstantiality. Sometimes in schizophrenia patient, we also get concrete thinking or poverty of thought. So What are these flight of ideas and loosening of association? That is what you need to understand properly. Otherwise, it will just be very confusing in the exam. Because in many patients, you will actually get flight of ideas in the exam. But in a schizophrenia patient, loosening of association means that you will not understand anything the patient is saying, because each sentence patient is saying doesn't have any connection with the previous sentence. Like if I say that, I asked the patient that, do you think your life is worth living? Patient says, oh, my car is due for registration. Oh, I have to go to watch this movie. My mother is coming for shopping today. Oh, yes, I just missed that movie. Oh, the bus is going. Oh, I have a flight tomorrow. So what I'm doing, I don't have any association of each sentence that I am talking about, and I have not answered the questions that was asked. So when a person shows this kind of conversation, that each sentence they are saying does not have any association between them, that is what we call as loosening of association, which can be found in a severe form of schizophrenia. Now, tangentiality, circumstantiality is not important for exam because you don't need to go that much deeper. But if you want to know tangentiality and circumstantiality means it's a circle. That means patient, when you ask a question, patient will talk and talk and talk, but eventually will answer your question at the end. But in tangentiality, they will never answer your question. They will just talk and talk and talk. Okay? What is concrete thinking? Concrete thinking means that, like when we ask something to a normal person, they understand the literal, like they understand the actual meaning of a question. Like if I ask you that, how are you feeling today? And if I say, I feel with my fingers and toes. Now, this is something which is very puzzling for a lot of us, right? But if someone says like a literal response to some question like this, then that is what we call as concrete thinking. Like if I ask that, if there is a fire in this room, what you are going to do? Oh, there is a fire in this room. Where is the fire? So they don't understand the question pattern. Okay, so that's concrete thinking. It's not usually commonly given in exam, so we don't need to bother about it. The next one is flight of ideas, which is found in many a patient mainly. Now, in case of flight of ideas, patient jump from one sentence to another or one topic to another topic, but they keep a little bit of association between each sentence they are saying. Like if I say, oh, I have to go to watch this movie. Oh, yes, I can only go to the movie by the bus. The bus is running away. So what I'm doing, I'm saying each sentence, but it has some connection. Like I want to watch movie. Oh, I have to watch the movie by the bus. Bus is running away. So each sentence has some connection, but it doesn't make sense a lot. Okay, that's what we call as flight of ideas. Now, there are some of the example of flight of ideas. See this one. So flight of ideas is characterized by rapid shift in the conversation topic. I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So what we are doing, every sentence has some connection, but we are jumping from one topic to another. Okay. No, tangentiality, it's a part of loosening of association. It does not have connection. Any loosening of association does not have any connection with the previous sentence. So That's how usually we make the difference between these two. Now in exam, as I said, that you will never get loosening of association, because in that way, you will never know what is this case all about. If a patient does not answer any question properly, that case cannot be made. So very unlikely you will get something like that in the exam. Most of the time it will be a lean because patient will answer your question eventually. But in many a case, you will get flight of ideas. Okay, is this clear for everyone up to this? Any questions so far? After thought form, then we go for thought content. Thought content, there are three things that we look for. Obviously, the delusion. Delusions, we already know what are the delusions we will be asking, like delusion of reference, control, guilt, grandiosity, and PSYCHIATRY or paranoid delusion. Sometimes you might get cases of eating disorder or body dysmorphic disorder. And in those patients, the thought content are overvalued ideas. That means even if the patient is totally normal weight and shape, eating disorder patient will always have some form of misperception about their body image and weight. So they will feel like they are overweight, or they will feel that they are ugly, or mainly overweight in eating disorder. Whereas in body dysmorphic disorder, they will always have an overvalued ideas that they have a ugly face or they have a deformed nose, something like that. So that is what we will call as the overvalued ideas. And in case of obsessive compulsive disorder, the thought content, we can say that patient having obsessional thoughts. So these are the three things that will be covered in thought content. And then we have CIJ, which is the cognition, insight, and judgment, that we already know what to ask. And then lastly, we will finish with 3R. So what is the risk of the patient? Now, risk is very important. If a patient having active suicidal or homicidal ideation, if a patient says that my life has no meaning, I want to commit suicide, life is not worth living, those patients having suicidal thought, they are always high risk. Now, it's not about only suicidal ideation that makes them high risk. If a patient having active hallucination or delusion, that is also a high risk patient. Because sometimes a hallucination patient can get command from their God or from anyone that kill this person or kill this one. So that can be a very high risk patient. So that's why suicidal or homicidal thought or active hallucination delusion, both of them will be in a high risk criteria. There are other ways to define this risk stratification, which we will discuss in our course. But this is the basic way to define that who are high risk. Patient does not have any active suicidal, homicidal thought, does not have any active hallucination or delusion, insight intact, judgment intact, that patient is low risk. Rapport. Rapport means that were you able to maintain a good relationship with the patient throughout the conversation? If you are not able to maintain a good rapport, is it going to fail you? No. Some patients are designed in that way that they will never ever make a good rapport with you, like a mania patient or a psychiatric patient. So in that case, you tried your best, but still patient was not having a good conversation with you. You can always say, I was not able to maintain a good rapport with the patient. Now it brings to this idea, never ever in the exam say anything wrong or anything false. If you haven't done anything, or maybe you missed insight in your history, never say in the exam that, yes, my patient insight was intact. That that is something taken very, very seriously in the exam. You can always say that I forgot to ask about the insight to my patient, but because my patient is not having any active suicidal or hallucination ideas, most likely my patient might have a like intact insight. You can always say that. The examiner will understand it. They will not fail you for it, but they can fail you if you say something which is false. Never ever do that. A lot of candidates think that, well, examiner is not listening. But trust me, they listen. When they are marking, they listen everything that you say. And if you have missed something, they already know that because they are taking exams for a long, long time. They know about each and every step that you do. Okay, so please do not say anything which is false or anything that you haven't done. Always say that if you have missed something, always say, I missed this one, and say sorry. So that's your rapport. Then is lastly, we say about reliability. So was the history given was reliable or not? Most of the time, if a patient does not have active hallucination, delusion, or does not have loss of insight, their history is reliable. But obviously, a person who is not having like intact insight or having hallucination, delusion, their history is never reliable. So then you can say that the history that was given by my patient was not reliable. That's why I would like to take a collateral history from a family member or anyone who is along with the patient. If a police bring a patient from the street, then you say that you would like to take a collateral history from the police. Okay, so it depends on who is available or who lives with the patient at least. And that's how you finish the MSc presentation. You don't need to give diagnosis. Remember it. If diagnosis is not a task, you don't need to say what is your diagnosis at the end. Yes, Dr. Estella. So about circumstantiality and tangentiality, we keep it for thought form. So when we say that my patient's thought form was linear, if you think that your patient has loosening of association or tangentiality, you can say that my patient's thought form was showing loosening of association, most likely tangentiality. But there was no flight of ideas or concrete thinking. I always use some negative finding as well so that my examiner understand that I know this thing and I'm trying to rule out those things. So it's a good idea always when you are presenting your MSc to the examiner, say positive findings first, and at the end say that my patient was not having any pressured or disorganized speech. So that's the way that examiner knows that, well, this candidate knows what she is doing. No, Dr. Pinke, we don't need to ask about derealization or depersonalization in this thought form or in MSc. And Dr. Abdul, we will do some MSc cages in our review sessions, which is the free 2-week sessions coming up from 30th of June. So far clear, guys? Any question? All right, so I would like to take a 10-minute break now and also keep your head organized now. I'll just keep this slide in front of you so that you can remember what we have discussed. Okay, so we'll take a 10-minute break and then we'll again do one particular case so that you understand how to take a history. All right, so thank you everyone. Let's take a 10-minute break. All right, everyone, let's start again. So now we normally do another class on AMC cages. So that will be your first class that we will start from for the 2 weeks free session that you are going to get from 30th of June. So that will be the class on MSc role play. But before we do that, I would like to go through with you a couple of cases that so that you can get some idea at least. So let's say this case, a veteran doctor brought by his wife as he was trying to hang himself with the rope since a cat was died during a surgery. You have to perform mental state examination. Performing MSc means taking a psychosocial history and present the examiner, like present MSc with the examiner. So obviously, we actually did this case already. So you have to, this patient will have depression, severe depression. So in this case, mainly you will start with your empathic approach, confidentiality, and always say sorry that this happened. Like always you can say that I got to know from the notes that something happened with a cat during the surgery. I'm really sorry to hear about it. I'm sure that you tried your best to save the cat. I'm sure that there is nothing wrong, that sometimes during an operation, this thing can happen to any doctors. And it doesn't mean that it is your fault, John. And as I said, that I am sure that you did everything possible in your hand to help this cat. I'm also sorry to hear that you were trying to hang himself, like you were trying to hang yourself today. Sometimes things can get very scary around. Sometimes things can get very sad around. But you have to understand that there are also healthy ways to deal with it. And that is why I am here. And I'm going to help you in every possible way to deal with this situation that you are having. I would like to ask you a few questions about what you are thinking and about your mental health. As a doctor, you do understand that this mental health is important and it can affect you immensely if it is not dealt with appropriately. So please let me ask some questions, and I want to assure you that these are confidential statements between you and me. So let's see that I totally changed the approach that I had initially. It just came out of my mouth. And this always will happen to you also. If you try to be nice to a person, you will know what to say. So you just need to think in your head that, well, I need to calm myself down and I need to show my empathy to this patient because he needs me at this moment. Right? So think in that way. Don't think these are the cages only in exam. Think that these are real patient who needs your help. If you can make these things like this is the only way to pass the exam. Trust me, the first-time candidate, they fail just for this. Because they feel that they have a very like 8-minute time to finish the case and the time is running. So I have to finish the case and then I will pass the exam. It's not like that. It is not about finishing the case in exam. It is all about your approach. It is all about how you deal with a situation given to you. And if you can show to the examiner that I am a good doctor, I'm not here just to pass the exam, I'm here to actually treat this patient. And that's how most of the examiner pass you. Okay, so think in that way. I'm sure that you'll change your approach immediately. So in this case, this obviously the history will be same like before. So we always in our course, we follow a same format for most of the cases so that you don't need to memorize a lot of history. And that is why the course becomes so convenient at the end that you have few history format in your head and you always use that in multiple cases. And that is the way to make your preparation concise, but very steadfast. And like it is so strong that you will feel very confident in the exam that you already know how to take a history. Whatever the case is given, you already have a format in your head that this is the way I will ask questions. And trust me, the history is the hardest part. The management, you will know. So in this case, patient, the positive points was like something like this. Patient was having stoop posture, very gloomy, well-dressed, no eye contact, having low mood, no sleep at night, slow monotonous speech, taking pauses in between, do not want this life, high suicidal intention, believes that he is guilty about killing the cat. Now, what these things mean by you? No hallucination, lack of insight, lack of judgment, cognition is okay. What do you think that this what you have to say in your MSc for this one? Yes, this is delusion. Very good, Dr. Mariam. But what kind of delusion it is? Yes, very good. Delusion of guilt, right? Very good, Dr. Khadija and Dr. Risha. Okay, so that's how you find out your finding in the exam. You have to know that what you are asking, and if patient gives you the positive finding, you have to catch that. You can't miss those positive findings. All right, so you'll just give this MSc finding to the examiner. Then there is another case. You are a HMO in emergency department of a major hospital about to see a 28 years old man who has been brought to you by police from the street. He is a schizophrenic patient on antipsychotic. He does not take his medication and sometimes takes ice. Further history, present MSc to the examiner. So again, you will start with the same thing. So all of the same things and give the confidentiality statement and then start your question like, how's your mood these days? Patient says, okay. Do you feel really low or high at any time? No. Sleep and appetite question, suicidal question. So when you ask that, have you ever think of harming yourself or others? Patient says, no, why I would do that? I am messenger of God. And God is asking me to do good to everybody. When someone says that I am messenger of God, what do you think that the finding that you are looking for? Or what you will mainly talk about in your MSc finding? There are two things in here that you should consider. Yes, Dr. Javiria, very good. Dr. Risha, yes. So we are thinking about two things, hallucination, because of maybe he's either he is hearing voices from the God, that means hallucination, or if someone thinks that they are messenger of God, obviously delusion of grandiosity. So two finding you have got just by this two sentence. Now to confirm your finding that is there any hallucination or not, you can ask then, can you hear your God? Yes. So that confirms auditory hallucination. Always ask the duration, that how long this is happening. Does your God give you any other command? It's very important. If there is a auditory hallucination, you always try to find out command hallucination. That means, is there any other command, like any any harmful command coming from the person. Then you want to also rule out visual hallucination. So you can ask that, do you see God? No. So that rule out your visual hallucination. So you have found auditory hallucination in here. You have found delusion of grandiosity as well. When you found delusion, rule out all other delusion. Like do you think someone is trying to harm you or is spying on you? He says no, but all other people jealous of me. Now, there is a delusion called delusion of jealousy. And that's actually, sometimes we keep it under delusion of persecution as well. So if you use the term delusion of jealousy, or if you use delusion of persecution in here, both of them are fine. And then obviously you will ask all the delusional questions. You will also ask thought insertion, thought withdrawal, and thought broadcasting questions. Then we ask about insight. Do you feel or do you believe that you need any medical help? Patient will say no, because I'm messenger of God, I don't need any help. Then ask about cognition, ask about judgment. So if there is let's assume that if there is a fire in this room, what you're going to do? Patient says nothing, God will save me. So that means lack of insight, lack of judgment. And lastly, you will just finish with heads, SADMA, past medical history, family history. Now, remember one thing. When in the question, they give you something like, if you see here, he admits taking ice at time. Now, sometimes there is a term called drug-induced psychosis. So we always will ask that question in here, that I understand from the note that you take ice sometime. When was the last time you took it? How frequent you take it? Is there any other recreational drugs that you take? Because if a patient took ice last week, obviously the effect will not be here now. So that way you can rule out possible drug-induced psychosis. And then you will just present the MSc just like this. Like, I would like to present the mental state examination of my patient, John, a 28-year-old brought by police from the street, the reason being unknown. He is appropriately dressed according to the weather, unkempt and not well groomed. He was not very cooperative with me, but he is maintaining eye contact and his body posture appears to be okay. The rate, volume and tone of his speech is normal. Mood, according to him, is okay, but the affect that I have observed was disturbed, which is not congruent with his mood. His thought form is linear, but there was no loosening of association, flight of ideas, or tangentiality. Regarding the thought contents, he is having grandiose delusions as he thinks he is a messenger of God, and also paranoid delusion as he thinks other people are jealous of him. Regarding perception, he is having auditory hallucination as he can hear God, but no command hallucination or visual or tactile hallucination. He is oriented to time, place, and person. His insight is poor and judgment is impaired. He is not maintaining a good rapport with me, but also his history appears to be unreliable. So I would like to take a collateral history from the police. In terms of risk, he is in medium to high risk because most likely he is having relapse of schizophrenia with active hallucination and delusion. He is not compliant with his medication. He has no insight and judgment. He abuses illicit drugs, and he does not have proper support because he is living in the street alone. Now, there was a task here specifically about risk assessment. If you see, present MSc to the examiner with risk assessment. So then that's why we actually gave a lot of findings in here that why we think that this patient is high risk. First of all, obviously, a couple of things will make a patient high risk. One of them is male sex. Second is patient who has active suicidal or homicidal ideation. Third, active hallucination delusion. Fourth, if a patient is having lack of insight and lack of judgment. If a patient does not have support, that means living in the street, something like that, even some like having financial issues. If a patient having, like you can say that any drug abusers, they are usually high risk population. So lack of support, having suicidal, homicidal, or active hallucination delusion, those are the patients who are high risk category. So you have to say that why you feel that this patient is high risk. Management usually does not come in exam, but in terms of any psychiatric management, we follow short-term and long-term management. In the short-term management, if you are in a hospital, then if a patient is high risk, you have to admit the patient in the hospital, even if the patient does not give you the consent. All right, so patient needs to be admitted in the hospital, even if patient says that, no, I'm not going to get admitted. This is one of the time where you can admit the patient or you can treat the patient without the patient consent. Okay, so this is the Involuntary Mental Health Act. Under the Involuntary Mental Health Act, you can admit this patient because this patient is high risk for himself and others. So you will admit the patient to the hospital under psychiatric team, and you will involve a acute care team for this patient. The acute care team, which is the ACT, it is consist of a psychiatrist, psychologist, and a mental health nurse. They will first assess this patient. After assessment, they will also do a complete organic workup, including all the basic blood tests and toxicology screen of blood and urine. So which means full blood examination, inflammatory marker like ESR-CRP, liver function, kidney function, thyroid function, and a drug screening of urine. So that's the organic blood test, which will be done first. A psychiatrist might put this patient on an antipsychotic. Once patient is stable, then psychologist will be involved to provide some support like a CBT. And throughout the admission in the hospital, mental health nurse will assist. In the long term, when you will be discharging this patient will be discharged under the care of a community mental health worker. And that community mental health worker will assist this patient in the community for any other follow-up or any other referral this patient needs. You can also arrange a social worker for him to take care. If drug abuse is a problem, you have to refer this patient to a drug and alcohol rehabilitation center. And because it's hospital, you will not be able to review this patient regularly. You can always write a letter to his GP or to her GP who will regularly follow it up. So that is the long-term management. Now, CT scan is not needed for every patient. Okay, so forget about it. It only depends on, like, sometimes if it's a delirious patient, especially elderly patient, then only we do it, otherwise no need. So that's actually the case. Now, I would like to do a case with you. Is there anyone who is like who already started the preparation and knows a little bit about the clinical and wants to do some role play today? Anyone who wants to do a role play? Yes, Dr. Brad, you can do it. All right, so I will unmute you.
Hey, Dr. Ashen. Hey, everyone.
Hi, Dr. Brad, how are you?
Good, thank you. How are you?
I'm good. All right, so let's do this case.
Sure.
I'll give you the case just in a minute. So we'll follow the same thing, like you'll get 2 minutes to read this case and think about what you would do.
Mm-hmm.
And we'll do it as a 8-minute station.
Okay.
So this is your case. Your 2-minute time just started.
Okay.
All right, so this is your patient. Your patient name is John. You can start.
Hi, John. I am Brad. I'm one of the doctors here. So I can see from the notes that you've been having some issues today. Can you tell me
Yes,
more?
I am having issues. This is a filthy hospital where there's cockroaches in here. I can't stay here. Just let me go home. This is a dirty area and I'm a patient here. Why there is so much cockroaches in this room?
Okay, John, I understand your predicament.
No, you don't. You don't understand anything. It's just filthy. How come anyone live here? Oh, this is cockroach in my shirt. Oh, it's crawling all over.
Yeah, I can see the cockroaches. If you just give me a little bit of time, I will ask you a few questions and then I will ask one of the cleaners to come and clean the room, okay?
Why don't you ask now? Because you can see the cockroaches, right? So why don't you?
See the cockroach. Yeah, so I will ask them in 5-6 minutes after I ask you a few questions. Is that all right with you? Because I'm here to help you.
I don't know like how you are helping me. This is cockroaches in here, and you want to just ask questions rather than asking the cleaner to come here.
Yeah, I will tell the nurse right
dirty.
now, and until it takes like 5-6 minutes for them to come, we will have a quick chat. Is that okay?
Yeah, whatever. I can't bear here anymore. I just want to go out.
I understand. John, before we move on, I just want to reassure you about confidentiality. Everything that we talk about here will remain between us unless it is of harm to you or anyone else. And you should know that I am here to help you with any way possible. And you know, if the cockroaches are the problem, we will take care of that. Okay?
Yeah, I'll see.
Okay, so I understand that you had a surgery about a day ago. How's the pain?
Yeah, it's fine. I'm not having any pain anymore.
Okay, good. And how's your mood?
Okay, but these cockroaches are making me crazy.
Sure, the cleaner is on their way and they will take care of it, okay?
Yeah.
Did you have a good sleep last night?
Yeah, I was, but this morning these cockroaches were crawling in on my shirt, on my body. I couldn't sleep at all.
Yeah, I understand. It's very frustrating. Have you had anything to eat yet? How was your appetite?
Yeah, it's okay. It's just filthy room.
Okay. And have you had any nausea, vomiting?
No,
Okay. And have you had any fever?
no.
Have you had a bowel movement yet?
Yeah, I had in the morning.
Okay. And do you have any issues with your urination?
No.
Okay, that's good. And tell me, do you, and I'm going to ask you a few questions which may seem a little bit strange, but these are screening questions that we ask from every patient, okay?
Okay.
All right. So besides the cockroaches, have you been seeing anything else or hearing things that may not be there?
What do you mean? Do you think like these cockroaches are just made of stories?
No. I'm not talking about
These
cockroaches.
cockroaches are real.
Yeah, of course they're real. I'm talking about hearing other things. Like, have you been hearing like unusual things?
No, I can hear you only. There is nothing I can hear apart from it.
Okay, how about feeling things on your skin or under your skin?
I can feel these cockroaches crawling on my skin.
On your
If you're
skin or
asking,
under your skin?
it's all over. It's all over on my skin.
Sure. Got it. I know it's very frustrating, and we'll take care of that.
Oh, there is a cockroach on your shoulder, doctor. Just there is a cockroach.
Yeah, sure. I'll get rid of it. John, have you ever thought today like about harming yourself or anyone else?
No, I'm not doing anything like that.
Okay, good. And do you think that you may have special powers?
If I had, then I would kill these cockroaches, trust me. But I don't.
Understood. And do you think that thoughts are being inserted into your brain or getting withdrawn from your brain?
No.
And do you think other people are spying on you or out there to get you?
No.
Okay. And do you think that your thoughts are being broadcasted on TV or radio?
No.
Okay. And John, do you think that you may benefit from some medical help?
What kind of? I already got medical help. You guys like treated me for the shoulder problem.
Sure. No, regarding your mood and mental issues.
No, I'm perfectly fine. Why would you need help for that?
I understand that.
This hospital is not good. This is a filthy hospital, a dirty hospital, which should not be here at all.
I agree. Okay. And suppose this room catches fire, what would you do?
There is fire in this room? Where is the fire?
No, there isn't any fire. I'm just asking supposedly if there is a fire. That's all right. And do you know where you are? Obviously,
yeah, in the hospital.
Okay, and do you know who I am?
You are the doctor?
Okay, and do you know what date it is?
No, I don't.
Okay, that's all right. All right, John, thank you so much for your help. I'm going to talk to the examiner and then I will get back to you. And the cleaner is on their way to clean the room, okay?
Yeah.
All right. Okay, dear examiner, today I talked with John, 47-year-old patient in the surgical ward after dislocated shoulder surgery. So he's been quite aggressive and has been seeing cockroaches. So I've been told to see him. So his appearance is well-groomed, well-kept. He wasn't much cooperative and he was distracted by seeing cockroaches. His speech was a bit pressured and he was talking quite loud. He had visual hallucinations and he was seeing cockroaches, but there was no tactile or auditory hallucinations. And his thought form was linear and logical, and his thought content there was no delusions and no thoughts of suicidal homicide. He didn't have any insight, and he was not oriented to time, but was oriented to place and person. And he lacked judgment. and his history was not reliable. So I want to take collateral history from the nurses in the ward, and I consider him as mild to moderate risk since he is in the ward, and he did have a good rapport with me. So what I, yeah.
I'm up. Thank you. Wow, that's a really good time, Dr. Brad.
Thank you.
I'm really appreciating that the timing was really good. Yeah. And like the way you did, it was really good. I'm happy that how you did it. The approach was perfect.
Thanks.
Okay. Now, the only thing that I can say in here that never ever say that you can see the cockroaches. Because if you say that you can see the cockroach, then you actually, like, you are also saying the same thing like the patient saying. We never will say that statement that we will not say that I can see the cockroaches. You can always say that I can see that you are stressed. I can see that you are upset, something like that. But we will not say like, I can also see the cockroaches like you. Okay, that's one thing. Another thing, in your MSc presentation, you did not comment on the mood. So what will be the mood about this patient?
Oh, sure. Yes. So the mood, it will be dysphoric and agitated.
Yeah. So no, like we will say that in terms of emotion, the patient's mood was okay, but the affect that I have observed was not congruent because it seems agitated or disturbed to me. Okay.
Yeah, sure.
And also, like you said that in the perception, you said that there is auditory hallucination, but no visual or tactile hallucination. But patients say that he can feel the cockroaches are crawling on the skin. So if cockroaches, like it doesn't mean that on or in, if they feel that it is crawling, we can always say that there is a tactile hallucination.
Sure.
All right. So I think these are the two things that is missed, but everything that you have done, it was great. Okay. It is a pass, this station.
Thank you, doctor.
Thank you. Best wishes for you. All right, guys. So see that this is exactly that how we want you to perform as well. So if you do this like this, if you have that much confidence in your voice, there is no examiner who can fail you. But that confidence doesn't come in one day. You have to prepare yourself day by day, and you will gain that confidence in you that whatever you are saying, yes, that is actually, I'm doing these things because I know, because I already know these things perfectly. Only that time, the confidence voice will come out. Okay. Otherwise, you will be like, if I do it with a beginner, they will stutter this case a lot. Like this is like keeping the nerve calm in these cases. It is not easy because multiple times you will be disrupted by the patient and you will forget that what you asked and what is your next question. So keeping yourself calm, and you don't and not getting into the patient's thoughts is very important, because they are there to distract you. They will try their best to distract you in every possible way. So for you, you don't think anything else. You always say yes, yes, yes. It's like Dr. Brad has done. Like when I say that there is a cockroach on your shoulder, that is the correct approach. That yes, that's right. Thank you so much for telling me that. That's fine. And then you move on next. So you will not get stuck anywhere. Patient will want you to get stuck or distracted. But if you do a lot of practice, then you will know how to deal with this kind of stuff. All right. So that was a great one. Inside was not intact. I said that, like, I don't need any help in this mental health regards. So inside was poor. Now the good question. Sometimes if your task is to just present your mental status examinations to the examiner, it doesn't need that you have to ask heads, SADMA, past medical history, all these things, because that is not a part of MSc. If you think that you are running out of the time, if you just finish the MSc component, which means that mood, you can ask about suicidal thoughts, hallucination, delusion, and then you are already getting the speech, thought form from conversation, and then ask about insight, cognition, and judgment. If you just do that, you will be in time as well. You will be able to finish it in time. And then you present your MSc for, usually you should at least take 2 minutes for MSc presentation, and that will be the perfect case. Any question, guys? And again, like drug and alcohol question, whoever asked, I can't see your name. So drug and alcohol question is not much important in here because you don't need to give your diagnosis to the examiner. So if diagnosis was the case, then yes, you have to ask all those head, SADMA, because it might be just a delirium because of alcohol withdrawal. So you might get that finding that patient was a heavy drinker during hospital staying. He did not take any alcohol and now getting alcohol withdrawal, and that's causing the delirium. So that's usually this case all about. So when diagnosis is a task, then you have to ask more history. You can't just ask MSc component at that time. And how you can rule out delirium? When you ask about cognition, if a person is oriented to time, place, and person, that patient is actually not delirious. So orientation will be disrupted if the patient is delirious. Okay. Any other questions, guys? So that will be the end of our today's session. Actually, we will do more of these cases in our free 2-week session. I'll just go a little up and answer some of your questions, and then we will discuss about the course, because you might have a lot of questions about the upcoming course, and then we'll just take a 10-minute to discuss those things. Okay, let's see that if there is any question that I missed. So Dr. Caldwell, if I perform procedures well in psychiatry, but I fail to diagnose the disease, will I be failed? There is a high chance if diagnosis is a task, and if you say it incorrect, there is a chance you can fail. Because mark comes as a global score, we will talk about the marking in another class, and you will understand how the marking happens in exam. And Dr. Mariam, the difference between circumstantiality and tangentiality means that it is a part of loosening of association. In a tangentiality case, when you ask a questions to a patient, they will not answer that question properly. They will just jump, and then they will never ever come back to answer your question. But in a circumstantiality, they will eventually answer your question. Like if you ask, how's your mood these days? Patient says, yeah, I want to watch a movie today. My mom is in the car. Oh, I have to catch the bus today. Yeah, my mood is fine. Okay, so if eventually I answered the question, that becomes circumstantiality. If I don't, that becomes tangentiality. Now let's talk about the course a little bit. Before we do, let me show you the course details in a video form first. And then if you guys have some questions, just feel free to ask me. So give me a minute. So first, let's hear this one. And then if you guys still have some question, we will discuss about the course. Okay. All right. Thank you so much for watching. So that was actually the course detail that you guys wanted to know. If I give you an idea, because me and Dr. Cynthia will take the most of the classes, and you will get classes from Dr. Cynthia in our free 2-week sessions. So we divide the classes mainly on doing role play classes and also doing theory with subjective role play. So first of all, obviously, you will get a full theory sessions with us, covering almost everything that can appear in the exam. And we always follow a cluster-wise theory discussion, which you will see in our free 2-week session, that what is actually the cluster-wise theory discussion. We do the role play on those clusters. Like if we do a cardiology class, then we will do cardiology role play. And then we also have role play classes on some recent important cases. And Dr. Cynthia usually takes those classes, the recent ones, and you get to do role play in those classes. And that is just a role play classes. Okay, so you do the role play, she discusses the cases, and that's how it happens. There are mainly two kinds of role play classes. One is subjective one, another is sample question related. We have a 1 month physical examination class, which will cover both online and face-to-face one. You get mini mock exams every 6 weeks. And also, you know that you get note available in your software until you pass. And also you get the recordings in the software for 10 months. You also get discussion classes on job hunting, some career pathways, how to write a CV, selection criteria, RMO campaigns, and also we help you with job reference if you need, and with upper registration. You also get to discuss about your problems with us. Every month, we usually have a mentor discussion session, and those mentor discussion sessions, usually candidates come to discuss about what issues they are facing. If they need any help with any registration or job related questions, we usually help them. You get CPD hours if you join our classes. There is no specific CPD hours. If you join classes, you can add these CPD hours in your dashboard. You also get a course completion certificate, which you can use as a bridging course during your registration. You already know the cost, which is $899. The duration of the course is 5 months. There is 3 days class in a week, which is mainly on Saturday, Wednesday, and Thursday. If you miss those classes, because it can only happen at evening time, because we work in here, we can't take class during morning. So you can always go through the recordings. So that's pretty much the idea that you will get in your course. I can assure you that this course is quite extensive one. And also one thing which you should always consider when you choose a course is that when you are a beginner, you will need at least 2-3 months to even understand what you are reading or what questions to ask to your mentor. If you're thinking to take a course which is like 2 months, by 2 months, all your questions will be unanswered because you will not even get to that point to ask questions. You can only ask questions when you have some idea about the cases, which usually takes 2-3 months. So that's why we usually keep it like lengthy like this, 5 months. But the thing is that most of you will need preparation for at least 6 to 7 months to appear the exam. So if you continue to take the preparation for 5 months with us, you will not need more than 2 months to appear the exam if you're really doing hard work. So 6 or 7 months, most of you will be able to appear the exam if you want. But it always depends on someone's speed of giving the time. Some people give 2 hours, some people give 8 hours. So obviously, the person who is giving 8 hours in a day, they will be able to appear the exam faster than the other one. Now, this exam is not a race. We all have our own situation. Some of you might have a one month kid. Some of you might not have any kid. Some of you might be just an intern. So all of your situations are different. This is not a race that who can appear the exam and pass earlier. It's your decision when you want to appear the exam. And the important thing is that if you are passing the exam or not. So make yourself in that way, think in that way. Someone might pass even 2 years before you. Doesn't mean anything because your life might not be that easier like the other person. So you are trying your best. That is what you really need to do. If you try your best, you are satisfied with your hard work and you can appear your exam in your own time. But when you appear, make sure you pass the exam because I need you to pass if you are from our course. Okay, so that's actually about it. Now we already started the course admission. So if you already want to get admitted, you can always ask questions in our messenger, send an email to the email that is given to the group, and then we can always start the process. It takes a little bit time, so don't get frustrated that if you are waiting for 1 or 2 days to get a reply from us, because we work here. It takes a little time for us to get back to you, and because this is the admission time, sometimes we get like hundreds of messages in one day. So it can take a little time, but please don't get frustrated about it. We will obviously get back to you. So if you start your process before the free 2-week session start, you will, by the time the class starts, you will be totally fine. You will get everything that you need for your preparation to start. Okay, so that's all about the course, guys. And always make sure that when you choose a course, especially for your clinical, you have to be satisfied with it. There is no other way around, because you don't have that much money to waste it all around, like, let's try this one, let's try that one. And it's not like that. Jumping from one thing to another will not help. Fix your mind that, well, I'm liking this class, I will go for it. I don't like this class, let's try something else. So in that way, and make sure you have at least one steady partner who you can start role play. And always, like, if you are starting this course or any course, make sure you at least start reading the handbook of AMC Clinical, so that you are at least oriented with what actually AMC Clinical means. So that when we start our class, you will know that, well, this I have read in AMC Clinical handbook case. So that's a good idea. And you have to finish the handbook. So please make sure you start reading that as well. And best of luck for everyone. And we will see you again on 30th of June with the free 2-week session. Is there any questions, guys? Unfortunately, there is no other intensive course. Like, we don't have any short courses. This is the only course that we take. And we take like only 2 courses in a year, and we make sure that the students, they are joining in the course, they get well treated. Okay, because we don't run like courses in every 2 months, only 2 courses in a year, but the people who join the course, they get everything that they want. Okay. And if there is anyone who is already booked, like Dr. Huria, if you already booked your exam, you can always ask us to give you the access to the previous batch recording. We always help the candidates like that. So you can continue joining the live sessions with us with the new batch. But if your exam is booked, if you send us your exam date with confirmation letter from AMC, we can always add you to the previous batch recording, and you can always finish the course in that way. And you can just join the role play sessions, do the role play with us. Regarding the books, Dr. Sweetie, AMC Clinical doesn't need any book. It's all about like the course note that you need. If you need a book, the book only thing is the AMC Clinical Handbook, which is usually important, and no other book is needed. There is 2 installments. If you start now, at the initiation of a course, we give 2 installations. So you can always make the payment half in the first 2 months, and then after 2 months, another half. And you can always reach us, Dr. Abdul, by messenger, or also you can have my email. So we have our email, which is given. So you can always use this email firstaidamc4536@outlook.com. So if you send us an email in here, we will always be able to answer your queries. We have a soft copy of clinical book, which will be provided in your course. And only one another thing, like if anyone wants the previous course recordings, like if your exam is in 1 or 2 months, you will obviously not get 5 months to finish the course. You will need something to finish it in 1 or 2 months. You pay the full amount, and then you get the whole recordings, and you get the whole previous batch. So you can finish in that way if you want, always. But you have to have your placement, and then we can always allow that. Yes, Dr. Curtis, you can do it. If only thing is that the condition is you have to have a placement for your exam. And if you pay your full amount, yes, we can allow you the access for the previous batch, and then you can finish it in your own time. Okay, send us message. We will always work with you in every possible way. That is how we make convenient for everyone. People join the course in the middle, which no one allows, but we allow them, and we allow them to finish the course with a new batch. So any problem you have, we always try to give you some solution to that. You will never ever come to us with a problem and we will say, no, we can't help it. We'll give you options, and you can always try with it. And then you can finish. All right. I'm very sorry to hear that, Dr. Karthi. It is very unfortunate, I know. Send me a message, Dr. Karthi. We'll find something out. Okay. All right. So any questions, guys? I hope you like the course today, like the class today, and eventually we will see that you can always wait for 2 weeks free session to understand the course much better and then join. That is actually the best way to assess a course. Someone giving you one class as a trial class, that doesn't mean anything. Anyone can take a very good class, but at least take 1 or 2 weeks with them and then decide. Okay. All right. Thank you, everyone. Have a good night. It is very nice to see a lot of you here. We'll see you again. Bye. Good night.